All right, you guys. So we are back to talk more about pulmonary diseases. And what we have here and where we're going to dive into today is pleural effusions. And we've talked about this a couple of times with some of our other diseases and disorders. But what we're talking about is fluid, some sort of fluid that is sitting here in the pleural space, that will start to impact everything around it. So we've got fluid that is accumulating in the pleural space. So let's just jump right into it. So when we look at the pleural effusion, what we're talking about, like I said, is the accumulation of fluid in the pleural space. And when we have a fluid that is infectious, we call that specifically an empyema. If this were to be blood in the pleural space, we would call that a hemothorax. So there are different names depending on what the fluid is that's accumulating here in the pleural space. So when we get this, we get all of this compression of the lung. We get all of this added pressure that's in the intrathoracic cavity. We get all of this addition to the pleural space that starts to shift and move everything away from the affected side. So just jumping ahead a little bit, getting a little overzealous here, but if we have this pleural effusion, what's going to happen to the trachea if that effusion is big enough? Yeah, it's going to shift away from the affected side. Anytime that you have something that is occupying space, whether it's air or fluid, it is going to push the trachea the other way. So if it's space occupying, it is going to push the fluid the other way. So with that increase in the intrapleural pressure, you're going to start to see that the affected side, you'll start to have some atelectasis on that affected side. And you start to see that with that increase in intrapleural pressure, you start to squeeze on the mediastinum. If you start to squeeze on the mediastinum, as we talked about with pneumothorax, you're going to start to have the heart that cannot expand and contract. And you get the compression of the great veins or the great vessels when you have that squeezing of the mediastinum. So this is another disease or a disorder that can lead to an increase in intrapleural pressure, which will increase the thoracic pressure, which will cause the heart some strain. So if the heart is straining like that, what do you think is happening to the cardiac output? Yeah, we're definitely going to see that cardiac output start to decrease. What's the heart rate going to do to try to improve or compensate for the decrease in stroke volume? Yeah, we're going to see that heart rate increase. So be thinking about, you guys have seen enough of these conditions and you've seen enough of these disorders that once you understand the etiology or really the pathophysiology, you can start to imagine and identify those clinical manifestations that your patient will present with based off of those changes to the anatomy. So when we look at this image here, we've got the parietal pleura, we've got the pleural space, and we've got the visceral pleura. Remember, the visceral pleura surrounds the vital organs. The pleural space is between the visceral pleura and the parietal pleura, and the parietal pleura goes around the perimeter of the lungs, kind of around the lining the thoracic cavity. So when we look at this, this is a breakdown of the hydrostatic pressure, the oncotic pressure, and the pressure that sits in the pleural space. So when I look at this, my parietal pleura has a hydrostatic pressure of about 30 centimeters of water. And that's pushing pressure into the pleural cavity or the pleural space. When I look at the hydrostatic pressure on the visceral pleura, we have a little bit or a slightly smaller pressure, right? So I've got 24, 25 centimeters of water here, and I've got 30 centimeters of water here, creating a negative hydrostatic pressure. Well, whenever I bounce down to the oncotic pressure is sitting here at about 34, 35 centimeters of water, and it's equal on the visceral pleura side. So my parietal pleura and my visceral pleura, the oncotic pressure is equal, and it is equally greater than the amount of hydrostatic pressure that's going on. So when I look at the hydrostatic pressure and I look at the oncotic pressure, they both end up with a value of 5 centimeters of water. The only difference is the hydrostatic pressure is a negative pressure that's in the pleural space. The oncotic pressure is a positive pressure that's in the pleural space. When I look at the difference between these two, I end up getting a net pressure of 0 between the hydrostatic oncotic pressures within the parietal pleura, pleural space, and the visceral pleura. So this is a complex image to fully understand, but when you start to see that the hydrostatic pressure on the parietal pleura is greater than the hydrostatic pressure on the visceral pleura, and the oncotic pressure on both sides is about 5 centimeters of water greater than the net difference of the hydrostatic pressure between the parietal and the visceral pleura, it ends up being this net force of zero between the two pressures, between the two structures. Take some time, digest this. This is something that's going to take a minute for us to fully embrace. When we look at different diagnostics, some of the diagnostics that we can use is a chest X-ray. We could use a CAT scan, but chest X-ray usually is something that we can use to identify the pleural effusion. We can use point-of-care ultrasound. With the point-of-care ultrasound, it can identify pleural effusions as small as 20 to 50 mLs. 20 to 50 mLs of fluid. We can see that here in the pleural space. So one of the ways that we do that with the ultrasound is if we can identify the diaphragm, we identify the diaphragm and we see that diaphragm moving, it should go kind of left and right this way. And if we have this big blob or this big dark spot above the diaphragm, well, we should be seeing more of a tissue rather than a fluid. So this would be an indication of a pleural effusion. One of the names for this pleural effusion, or the signs with the pleural effusion, is what's called a quad sign. So QUAD, quad sign, is something that we can see with a pleural effusion. Chest X-ray, we're going to talk about that here in just a second. So when we look at the origin or our etiology of the pleural effusion, there's a number of different things that we can have. We can have a pleural effusion from CHF, congestive heart failure. It can be from a pleural effusion, right? We can have a pulmonary embolism that can lead to acute heart failure that leads to pleural effusion. It could be a pneumonia or a bacteria that is causing the pleural effusion. Some of the things that we would see or the patient may be complaining of is pleuritic chest pain. So we may have the patient complaining that they feel a sharpness or a tightness or a pain between their ribs. Shortness of breath, of course, we're going to see shortness of breath, and they will complain of a cough. So the cough is typically related to the amount of atelectasis that patient is having as a result of the pleural effusion. When we look at sizing the pleural effusion, you can have a small, moderate, or large, and it just depends on how much fluid is in the pleural space. If it's less than 500 mLs, or they're having pleuritic chest pain or pleuritic inflammation, then that would be something that we would call a small pleural effusion. When we look at moderate, this is going to be 500 to 1500 mLs, or a large pleural effusion, that's something that has fluid that is greater than 1,500 mLs. Then when we look at our causes, we want to kind of look at what is our origin of fluid. And this helps us break down that etiology a little bit more. When we look at the hydrothorax, this is a serous fluid that is collecting in the pleural space, causing a pleural effusion. A hemothorax, this is blood in the pleural space. Chylothorax, it's pronounced chylo. This is a form of chyle in the pleural space, and we're going to break these down a little bit more. You have pylothorax or empyema. This is made up of pus. Remember, we never call it a pussy fluid. We always call it purulent fluid, purulent. And then the last thing that you can actually have is a urinothorax, and this is actually urine that is collecting in the pleural space. So you've got a lot of different fluids of origin. You've got causes. We're going to break down the symptoms a little bit more, but breaking down the size as well are all components that you need to be familiar with.